Okay, we're going to try and start, that clock is slightly fast, but we are going to try and start as close to time as possible. Good evening, everyone. Thank you so much for joining us this evening. My name is Rowan Conway. I am Director of Development here at the RSA, and it's my great pleasure to welcome you all here tonight for tonight's special event. We're filming this evening, as we always do, and we will be live streaming over the web, so welcome to those of you who are joining us online. And a reminder that the hashtag is RSA Health, so please do tweet anything that you find interesting that you hear today. Now that the housekeeping notices are over, I'm delighted to introduce this evening's event, which rounds off a day of activity. We've been very active today talking about social models of care and social movements in health. We have been exploring how to create social movements in health which empower patients, carers and communities to take action for improved health and well-being. Now, it is very much in the public dialogue that health services are under sustained and growing pressure with increasing demand for care and squeezes on finances. The NHS 5-year forward view calls for large-scale transformation and new models of care in what it says if we are to maintain a sustainable and universal health service. Now, this is much a very public debate and something that we want to get into this evening. So we have been working as one of the national partners in partnership with the NHS England, with Nesta and the New Economics Foundation, exploring how social movements work across health and social care and seeing if they can build stronger and more connected communities. We're working closely with the new care model vanguards and the wider health and social care system in England to understand and identify and share learning from current good practice. And Halima will take us through some research that you will be able to access outside that we have published today. In tonight's event, we will consider the potential of social movements to organise and lead change, and our aim is to have a probing discussion about what it takes to build and sustain effective innovation in healthcare. We're delighted to announce the publication of Nesta's primary report that illustrates the power of people and movements. If you haven't picked up a copy, please do. They are outside. But I'm going to move straight on to the show. So it's my great pleasure to welcome our expert panel, and they are going to come through and each do a short lightning talk to go through their views of health as a social movement. We're going to start with Halima Khan, who is Executive Director of the HealthLab at Nesta, which drives change to improve people's health and well-being. Halima has a strong track record of public service reform and innovation, with a particular focus on social care, health and disability. Now, she's going to be followed by Helen Bevan, who has the extraordinary title of Chief Transformation Officer at NHS England in the Horizons team. Helen is acknowledged globally for her expertise of large-scale change and has been looking at how to use social movement principles in change both within and outside of the NHS and translating it into practical outcomes and practical action. Jos de Blok, who was our 2014 Albert Medal winner here at the RSA, is founder and CEO of Buurtzorg, although it's his life's work to make CEOs redundant. He and his team created a new model of care, a new self-organising model of care that's nurse-led, where patients and professionals are empowered to find the best solutions to their healthcare needs. And then finally, we'll hear from Higgins, who's Director of Public Health at Oldham Council, and he's working with the Greater Manchester Devolution team around arts and cultural change and health and community development, and using arts as a core public health tool. So I'll hand over first to Halima, who will give an overview of social movements as part of a conceptual framework for health. We'll then hear opening presentations from our distinguished panellists before moving on to a wider discussion with yourselves. And we'll do that across the panel, so get thinking about the questions that you'd like to ask. But without further ado, please join me in welcoming Halima Khan.
Fantastic. Well, thank you, Rowan, and it's great to be here. And HealthLab at Nesta is all about building a people-powered health system that is for people, by people, and with people, which is why we're absolutely delighted to be part of this programme, working alongside NHS England, the RSA, and NEF. And I'm really, really excited about being part of this fantastic panel. I think Helen, you really are the queen of social movements in health. So we are honoured to be in your presence and building on all of the work that you've done. You're doing amazing stuff in the Netherlands, and Alan, you're creating a revolution in Oldham. So we are in great company. So I'm here to tell you a bit about this report that we have launched today. And firstly, I'd like to thank all of my co-authors who are here, and also all of you in the room. Many of you have helped us to create this this report, so thank you for your engagement. And we think it is perhaps quite a timely report. There does seem to be a sort of a surge of interest in social movements in a health context. There's also a huge amount of practice already out there, practice that we can engage with and learn from. And so this is really all about reflecting about large-scale social change, change that is accelerated through people, not methods, not processes. They may use methods and processes, but it's the people that are powering the change. And it's all about people standing up, speaking out and seeking change about the things that are most important to them, their loved ones, their neighbours, their communities. So that is what we're all here to reflect on and to learn more about. And a couple of sort of key insights, if you like, before I take you through some of the key conclusions from the report. The first is the very important fact that social movements are not new. That dramatic social change has been time and again driven by groups of concerned citizens coming together and creating change that matters. So that's the first very important point that I think we should bear in mind. The second point is that I think we should also recognise that social movements can look quite different to one another. So a couple of quick examples. If you think of the tobacco control movement, which was initiated, if you like, off the back of research that connected tobacco use and lung cancer, that looks and feels quite different to another social movement. Say, take the disability rights movement, a movement that is really all about rights, identity, and a new understanding of living with a variety of different conditions and so forth. So those two movements look quite different. Our challenge is, what are the defining and the common characteristics that link them? And I think also from those two examples, it's quite clear just how, what great scale social movements can operate at, and over quite long time periods, decades of work, and also how sophisticated their impacts can be, how multifaceted they are. So that's the second. And then the third point really is how social movements in their purest form are messy. They are vibrant, they are spontaneous, they bubble up from outside of formal institutions, formal power structures. And so by definition, social movements are there really partly to make the ways in which we normally do things, established ways of working, feel uncomfortable. And so it's really quite extraordinary when you think of it to have now leaders from our biggest public institution, one of the biggest, and the NHS, calling for more social movements. That is really quite an extraordinary thing, given what we know about social movements. But at the same time, I think it's possible to say, well, actually, that's really quite understandable. So if we think in terms of the fact that we're now, I think, there's a consensus around the limits of a treat and cure model of health, that actually it's quite understandable now that more and more people, even within formal structures, are looking for more socially driven methods of change. So if you like, that's a very kind of quick overview of really the backdrop, I think, to the research that we've done. But I think the best way into it is really to hear the voices of the people that we've been engaging with. And so this first one is really making just that very important point again. We must build and recognise and indeed honour the social movements that have preceded us and not talk as if social movements is a bright, new, shiny thing. This is a very interesting insight, and again, we heard it again and again through our work. So isn't this just community development? And it's quite a kind of a subtle point, really. So community development and social movements in health share many, many characteristics. Indeed, it might be possible to think of community development in some way as being a form of social movements. But I think social movements do go beyond community development. So there are social movements, if you like, that may share some of the characteristics, but not all. And actually, the kind of the citizen science model might well be quite an interesting comparison, if you like, that shares some characteristics but not all. And the other sort of important point on this is that I think social movements very much need to transcend above any one single place or institution. It is their persistence and their scale over time which really gives them their great sort of characteristics. This next sort of point that we heard through our work, which is about the relationship between, the moment at which a social movement comes up and bumps up against formal institutions is absolutely key, particularly in the context where the NHS is calling for more social movement. So this becomes a great, I think, a great sort of issue that requires more work, and we're very interested in thinking through kind of dynamic ways in which the interaction between institutions and social movements can evolve. And then I think this, in some ways, might be my favourite insight, which is, I don't know about you, but sometimes, particularly in the context of doing this research, I'm talking to lots of people doing brilliant, brilliant work, and they say, oh, that's a real coincidence you're doing work on social movements, because I launched one last week. And it's really subtle, because obviously the great power of social movement is its inclusivity, it's the energy, it's the passion. That's exactly what we want to develop and to grow. At the same time, if we end up using the term social movements to refer to literally almost anything that is vaguely social and involves more than one person, it is going to lose some meaning. And so that's the balance that I think we need to strike. So we've had a go at a definition that we hope is useful. I think a couple of things to pull out in terms of what's behind this definition. One is really reminding us all the time that social movements are driven by people, not by organisations. Organisations may well be part of social movements, but they can't drive them. This needs to be a people-led endeavour. I think the other sort of point behind this definition is to realise really all the multifaceted different sort of examples of social movements. So in terms of the personal, sort of affecting people's personal experience of their health, there are great examples around reducing cultural stigmas to do with particular health conditions, or promoting research for the treatment of particular health conditions. But equally, social movements can grapple with the very systems that people experience with respect to their health. So there are ways in which, if you like, the hospice movement is a brilliant example where we're actually creating a whole new model of delivering care that didn't previously exist. So many, many different ways in which social movements can be manifested. So what we've done is try to bring out some of the key characteristics, if you like, of social movements. And our reflection really is that it might be more fruitful to focus on how social movements behave rather than what a social movement is. And if you like, part of the reason why we think this might be particularly fruitful is it is actually aligned with this very spirit, if you like, of social movements. So not trying to sort of pin them down into a box, but more engaging with how is it that they affect change. And so here, I won't take you through these, but here are some very, hopefully, helpful ways in which, through our engagement with the literature and with practice, that you see how social movements can behave differently. And my favourite is the raging and the roaring one near the bottom. And I think that is key. That is key. We mustn't lose that. I won't spend too long on these issues, because I think we should move on to the rest of the panel. But this is just a quick sketch, if you like, on a possible path towards institutionalisation for social movements. And I think this is a field that we should engage in more collectively. So this is one sketch of how a social movement might change over time and become more formalised, might even create organisations from it. Our hunch is, and I'm sure you will share this, there are many, many possible paths which social movements could take over time. And then our conclusion really is that, having done the report and engaged with this, that despite the fact that there is a great deal of great practice out there, that people have been thinking and researching this for a great deal of time, it still doesn't quite feel that we have quite designed and created the models of engagement and deliberation and decision-making that are really required for a very much more productive engagement between social movements and institutions. Because I think the real prize here is there a model of engagement that values and strengthens the differences between social movements and institutions, rather than trying to turn one into the other or vice versa. So I think that is our collective challenge. I'd be interested in your response to it, and look forward to the discussion. Thank you.
Should we cue that up? Helen, over to you. There we go.
As somebody who has been a change activist and a change leader inside the National Health Service and the wider health and care system for a long time. Actually, this is my 26th year. I'm really thrilled to be here today, and really thrilled to see the primary report on health as a social movement. And I think that, I would agree with Halima that we've reached a particular place in time. And, as somebody who has spent many years kind of working with these principles, seeking to build practice, it kind of warms my heart to see this happening. So I got asked to define, my view of a social movement, so I stole one. I stole one from the Global Fund for Women. And again, I think it's interesting to look at this in the context of our health and healthcare challenges. A movement is a group of people with a shared purpose who create change together. Okay, we need plenty of that in the health and care system. And what we've got here is a set of criteria that make up a movement. And the one I particularly want to focus on tonight is the first one, which is about a strong pipeline of leaders. And the theme of my 8 minutes of glory this evening is, very often I think that one of the shortcomings of the approaches that we use to social movements is we think that social movements are about mobilising, mobilising people for change. And that's really important. But actually what is more important is our ability to build leaders. So more of that. So, very often it's difficult trying to be a movement leader in a health and healthcare world. And what I'd say is actually there's room for it all. Of course we need randomised controlled trials. Of course we need good science. And I think more than ever we need the kind of rallying around the things that really matter to make a difference. And I absolutely agree with Halima, that we're not starting here at point zero. We're building on, years and years of change and improvement in the health and care system using social movement principles. And, lots of examples, but just some of the ones that I've been involved in that I feel very passionate about. And down here on the right-hand side, the right prescription. And this was an amazing call to action that was led by the Dementia Action Alliance, which meant that in less than 3 years, there was a 51% reduction in prescribing of antipsychotics to people with dementia, okay, as a result of this call to action using social movement principles. If we'd have done that the way that we normally do it, which is to write a guideline for clinicians and try and impose it through regulations, we'd have no way we'd have got that. Another one is NHS Change Day. This is an amazing movement of frontline staff, patient leaders, people all over the system who on one particular day of the year take a specific action to make a difference to the experience and outcomes of care. And we've seen tens, hundreds of thousands of people engaging in Change Day. And the next Change Day is on the 19th of October. And another one here, the School for Health and Care Radicals. This is a school for activists using social movement principles. And so far, more than 10,000 people from 44 countries have been part of that. So, I agree with Halima. I think that now is the time, okay, that we need to be thinking about social movement approaches and principles and actions at scale. And the reason why is I think we've reached a point in our system where we have to disrupt. Of course we need small-scale incremental change, we always will, but it just isn't enough. When we see the gaps between where we are and where we need to be, we so need to embrace disruption. I love this quote here from Gary Hamel because I think it sums it up. And he says, our management systems of tomorrow will need to value diversity, dissent and divergence, okay, as highly as conformance, consensus and cohesion. Of course we need conformance, consensus and cohesion because we need safe, effective care for our patients and our citizens, but it isn't enough. Okay? If we don't build diversity and dissent and divergence, then our storyline is never going to change, and our storyline has to change. But I'll add another little comment here, which comes from Peter van der Merwe, and he says, if we're trying to be disruptive, social movement-orientated change agents, okay, what's the biggest mistake to avoid? And actually, he says it's about creating disruption at work, going into a system like an unguided Exocet missile. Because actually what he says is that disruption is about developing relationships, it's about connecting, it's about building change at scale. So, what I want to just show you for the rest of my little slot, is I want to just take you through one of the frameworks which actually appears in the Health as a Social Movement and primer, because it makes such an important point, I think, when we think about health as a social movement. And this comes from a researcher called Halima Khan in the USA. And what she did a fantastic piece of research about activists, okay, and who makes the most effective activists. And she talked about 3 different kinds of activists that she found in her studies. And the first kind of activist she called lone wolves. And lone wolves are people who they build power but because they've got information. And they are part of the system, so they work through advocacy, they work on oversight committees, they make public comments and they take part in consultations. Do you know what I'd say? If you look around the NHS and the wider health and care system, actually a really significant proportion of the way that we work with patient leaders and patient representatives is as lone wolves. Here's a comment from Annette McCannon, and she says, you know, what I'm ranting about is the way in which patients are being streamed into advisory subcommittees, the way we're being used as tokens and to help tick off the right box. Where is the attitude that patients are part of the team in healthcare, that we are partners? Why are we always being asked to participate inside a predetermined frame? When will we see co-design of new policies and ultimately co-production? That's classic, okay, lone wolf approach to activism. Okay, the second group she called mobilizers. Okay, and they build power through people. Okay. And what they're able to do, mobilizers, is to call on very large numbers of people. So if we want to call a load of people to action on a particular day or on a particular cause, mobilizers can call them to action. Okay, really important skill and capability. Okay, the third group she calls organizers. And what organisers do, in addition to what mobilisers do, is they build leaders, they grow leaders, they identify the people who can make a difference, they train them in a distributed network, they build community and they protect the strength of its community. So looking at the 3, which do you think is the least likely kind, of all those 3 kinds of activists, which is the least likely to be able to make big change happen? Which one do you reckon? Okay, lone wolves, okay? Where's most of our focus at the moment? Lone wolves. And why I presented this is because very often when we talk about social movement thinking and practice in health and care, we're talking about mobilisers. We think it's about getting loads of people engaged in change. And yes, that's important, but it isn't enough. Okay? What Halima Khan found, and what I find, is that of course we want people that are mobilisers, but the activists that achieve the most, okay, that have the most success, are a combination of mobilising and organising. So we really need to focus on building leaders. And I take this quote here from Joe Simpson. He says, "The great social movements get their energy by growing a distributed leadership." So I think actually one of the most important things that we need to be doing as we move forward, taking social movement thinking and practice to a different level, is to grow a distributed leadership. And finally, where do I think we need to be going? Actually, I kind of term I'd use to sum it up is we need disruption, but we need disruptive co-creation. You see, we're fixated at the moment, I think, in our system, in top-down and bottom-up change. And of course we need top-down and bottom-up change, we do. But, if you look at history, what it tells us is that breakthrough innovation rarely comes from inside the existing system. It's these people coming in and these perspectives coming in from the outside. And in addition, it's the new generation of leaders, the trainees, the students, the young leaders have got a huge role to play. And what we're talking about here is moving beyond the kind of service lens, the perspectives that most system leaders conceive the problems. And it's about bringing positive disruption into the system for faster change and bigger outcomes. And I think that's, it's what we need. And I think it's one of the biggest opportunities that social movement thinking and practice gives us in terms of health and care. And I say, bring it on.
So, wow. I'm Jos de Blok. I'm a community health nurse, and I worked for 15 years as a nurse. And I'm also an anarchist and an activist. So I was born as an anarchist, I think. Always causing problem at school. So always had work to do. And becoming a nurse was, for me, the most beautiful profession. Before that, I studied economics, but I quit my study after 2 years. And becoming a nurse was, for me, the most beautiful thing. I became a community health nurse, and every day was an adventure because I could do what I think was necessary for the community. So in that days, we didn't have a real organization around us. We just were professionals and working in a professional way with the community in the community. And then after some years, the whole way of organizing of healthcare changed in Holland. Between 1993 and 2006, I resigned my job. I became director, and I saw what organizations did with people, so what power and hierarchy did with people, and it became more and more difficult for professionals just to do what they think was necessary. So in 2006, I resigned, and with some friends, we built a concept. It's called Buurtzorg, and our idea was very simple. Let's build an organizational model which facilitates professionals to do what I think what's necessary to do. So I also had the experience. I had these 2 years of economics study, and I had this experience as a director, so I knew how the system worked. So one of my goals was what can we do to cheat the system? So, because the system, the healthcare system was creating more and more problems, in my opinion. So what we did, and it took us 1.5 years together with some friends, and we had a lot of beers and nuts and evenings. But we discussed what can we do to build a scalable model which can grow very fast and create a disruption in healthcare. So that was our goal in 2006. In Holland, a lot of people think that it's an accident, that it was just for nurses starting, and that after some years it was a lucky shot, but it was not true. So I agree with these principles that for mobilizing people and not disappointing people, you need to have a model which is sustainable. So what we did was, how can we work within the financial system that is creating some kind like an inner world where everybody who works in this world can do what they think is useful. So our model is based on very simple things like a neighborhood. A neighborhood is an environment where everybody can build a network. So the nurses who are working in the neighborhood have their informal networks, and they can use them to bring solutions. We said if a team is around 10 nurses, then they can organize everything themselves. They don't need management. I think nobody needs management, but and they will just do everything they think it's useful to do the right things to help people in a professional way. So that was one of the principles, and we also made a very simple business model. So we said if the income of every team is this, then they can survive every year. And if we have a little bit surplus, then we are sustainable, and then we are independent from the system. So that was the starting point in 2006, and at the moment we are with 10,000 nurses, and we have 4,000 care workers, and we are still working the same. So we have a very simple model, but every nurse, in my opinion, is a leader. So they mobilize now other people in the community. And if you look at, we have dealt with 600,000 patients in these 10 years. And also the patients became a member of the network. And they have families. And all these families became also participants. And you see that also the families, when we have parties, because we have a lot of parties, and all the teams celebrate every year they exist. And what you see when they celebrate is that the children and the partners of these nurses are also there. So the children are bringing the drinks and the food, and the partners are standing very proud that their wives resigned their jobs and started this from their own. So it started as a movement. Formally I'm the CEO, but I'm not needed anymore. So I'm traveling all over the world to tell the story and enjoy you, and so on. And what happens is that it's growing naturally. So it's a very organic way of doing things. And the idea that everybody thinks it's logic, so clients think it's logic, the nurses think it's logic, and now even all the system players think it's logic, and they also decided, the politicians, they decided that it's wise to make it the national standard. And that was, and one of the things was how do we navigate in the system? We never accepted anything we thought it was useless to do. So if the system said you need to use indicators for ulcers, I think the NHS is very fond of ulcers, then we said it's useless to focus on these kind of things. So ask just the nurses what kind of problems they meet and build your quality system on that. So every time again we started the discussion, if it was with the health insurers or it was with the ministry or it was with the care authority, we never accepted it just as it is. And what I see is a lot of organizations and a lot of managers just accept all these regulations as they are normal. But we create a lot of abnormal regulations, but that's just bothering the people to do their work. So we say to our nurses, don't accept to do useless things. So just start to discuss the things and try to find alternatives. So that was the other thing what we did. We gave all the authorities alternatives. So we said, it's useless to do this, but you can do that. Because only fighting and only arguing is not enough, I think. So all the time and we had a very open attitude and we will see what happens. So we said when there was a problem, we started to discuss how can we solve the problem. So a very open mind to everything which can happen. And what we saw that all the authorities started to talk together about what was happening. So even people I didn't know about, they were discussing what we were doing and said perhaps that's the right thing to do. So this was one way, but this was about community nursing. But for the long term, I see that it can be done with a lot of different professions. So social workers, doctors. We are now working with mental care. We have a part of youth care, and it's all based on the same principles. So, like there's a beautiful experiment in a village that the youth care workers they feel themselves as part of the community. They don't feel that they are part of the organization. And I think that's, for me, that's a beautiful example of how it should be. So the moment that people feel that the community is the owner of their activities and they're integrated in the community, a lot of a complete other dynamic exists than when people feel that they have to follow all kind of regulations and all kind of rules from the organization they're working for. So this is an example, and I'm very happy to be here again because it felt very good to get this. One thing I had to say, there was this journalist who wrote an article a few weeks ago, and he called me an anarchist, and he said he watched the RSA video from the medal, and he said that my English was so terrible. He wrote it in the newspaper. He says he talks like my uncle on the bar, and his English is terrible. And then the rest of the article was quite positive. Thank you.
Thanks so much for the invitation. I don't know how to move on from Jos's slides, but I don't actually have any. So if you get bored looking at me, you can always look back at that slide again anyway. And what I'm going to talk about is some work that we're doing in Greater Manchester around, the strapline is Live Well, Make Art. That's what it's become known as. That's its Twitter handle as well. And I'm going to tell you about what we've done, because that's useful for me, because every time I have to explain it to somebody, I learn a bit more about what we're doing and I understand it a bit more as well. I would also at this point declare my lack of credentials in terms of working on social movements. 2 years ago, I'm not sure what I knew of the term. It's only in that short time that I've read about it, read a lot of Helen's stuff, read some other stuff as well, and starting putting a lot of it, I hope, into practice. But what the main thing that the work we've got in the arts, health and social movement has got that's in common with some of the principles or the things that other social movements have is that messiness, complexity, uncertainty about where it's going. We've got all of that in abundance, but we've also got an awful lot of enthusiasm. And every time I go into a meeting where I'm thinking, oh, good grief, what are we doing here? I come away from it having had that feeling turned around by the energy of the people in the room. So it was about 2 years ago, and at around that time, there was a report being worked on, which eventually was called Due North, which was a look at health and health inequalities across the north of England. And Ben Barr and colleagues from Liverpool were doing some research, looking at the evidence behind engaging communities and why that was good for health. And there was a couple of, I went back to that report, that's what I was reading at the time, and he was quoting Amartya Sen, saying, the fundamental cause of inequalities in health is a relative lack of control and powerlessness of disadvantaged groups. Okay. Marmot around, well, earlier, what we need to do is create the conditions for people to take control over their lives. And then also in the same report about the process of getting involved together with others builds social capital that leads to health benefits. And it was that kind of logical thinking that was behind what came to be the start of the social movements work in Greater Manchester, that sense of wanting to find a way of providing the conditions for people to take more control over their lives. And there's many ways of doing that, but particularly one that we're going to talk about is social movements. So that was knocking around that time, 2 years ago, roughly. Then on to Greater Manchester devolution. And the deal was signed off in November 2014, saying that we would have power and responsibility control handed over to the authorities in Greater Manchester to run health and social care by April 2016. And there was a bit of thinking, oh, good grief, what have we got? It's kind of getting what you wished for in a way. But that was signed off in November 2014. And in the discussions around that time, social movement was mentioned in relation to health. And there was a meeting in Manchester Town Hall, and I remember standing up and saying, it sounds fantastic. However, I just don't know if when I talk about social movement for health, it's what you're talking about and what you're hearing. And it was from that I offered to do a bit of work just to try to understand what it is that we might be talking about, hence the reading up. The next signed document, the Memorandum of Understanding in the GM devolution story, was by July 2015. That was with Public Health England. And looking at promotion of health and well-being, but prevention of ill health. And we by this time, we were looking at concentrating the work into a number of programs. And we concluded that we wanted to have one which was about a social movement for health. But reading on it, it became clear that you couldn't really commission a social movement. You can't control it. That's starting from the wrong place. So we settled on wanting to nurture a social movement for health. And that's one of the 5 programs in the Greater Manchester Commissioning Strategy on Public Health, is that we would look to nurture. That felt like it gave us a bit of leeway. So we started putting together various proposals on this, but in fact, they were getting stuck. We needed some different ways of thinking. And it was through my previous association with community arts over, 20, 25 years, that I thought that whilst I think I'm an enlightened public health practitioner, the people I speak to are mostly people like me who present statistics and, all that stuff. And I really needed to engage with people who think differently. So I tapped into that community arts network. I got in contact with people in Greater Manchester I hadn't seen for some time, talked to them about whether we could look at a social movement for health, or as it became known as a social movement for active citizenship. That sense of not just wanting to talk to people about health necessarily, about what they could actually do for themselves or with others do for their communities. And thankfully, the people I spoke to, one is the chief executive of a major cultural organisation in Manchester, another is an academic with a long history in arts and health, another is a community arts practitioner with 25, 30 years experience in the field. And they all were enthused with the idea. They all brought different aspects to the thinking on it. We then thought that we need to reach out to more people. And of course, the way that you do this when you're in this line of working is to have a workshop. And we did that in the middle of Manchester. And really the idea behind the workshop, and this was November last year, was to ask people what excites you about these ideas If it went well, what would it look like? And we weren't sure how many people would turn up. In the end, about 30, 35 people came to the first meeting. We lined up various people to say things at the right moments. And we thought if maybe a quarter of the people who come want to stay engaged, then that would be great. That would be, a success. As it happened, all 35 people wanted to stay engaged, wanted to see where it would go next. And just that sense of, that's what happens when you bring people together. And the people who had come together were a mixture of people from the health and social care field, from my background, local government as well. We tapped into lots of voluntary sector arts organisations, arts practitioners as well, academics too, arts administrators as well. And it was that mixture that seemed to really spark something off in the day, which led to that very enthusiastic response. So 36 people filled with enthusiasm and wanted to stay engaged with it. The core group who put it together then met afterwards and think, crikey, what have we done? What's happened here? And how can we actually build on this? The intention was to have another workshop by February. That would have been February of this year. Of course, it took longer. It was May by the time we actually got back together again. But this time we were wanting to look at getting some more substance into this work. So looking at values and principles of what we're doing. We had discussions during that workshop as to how we could construct this. Ideas came forward. We've since written something out and sent it out towards the end of August for others to come back to us and comment on it. That's happening as we speak. We got about 45 people to this meeting. About half of those were people who had been at the previous meeting, so there was some sense of a growing interest as well. A key thing that we wanted to do was to look at whether we could start any actual practice from this workshop. And so we asked for volunteers to put their heads together around themes that we fed, but also that they could come up with, to see if anyone would do some work between that workshop and yet another workshop. We didn't want to have another workshop, we were just discussing what we might do. And I don't know whether it was just a mix of people on the day, but there was just no problem in getting people coming forward. 3 things were spin-offs from that. They're also part of the Health as a Social Movement pilot in Greater Manchester, working through the Stockport Vanguard. And there's one called Creating 100 Moments. It's underway at this moment. It has its own website if you'd like to tap into that. And that's followed up by another one, which is about community conversations, only just getting off the ground. And that's about talking to people about arts and health. Do they get engaged in arts activity? Would they like to do that? How would that relate to the rest of their lives? The third Tree of Life idea might not get off the ground. That's where these things go, I think. But it might get there. The aspect of arts in this, as opposed to community development work around health, which I've been involved in and highly value over the years, the arts stuff seemed to bring something additional, which was about inspiring hope. That sense of creating community seemed to be happening more readily through these spin-off bits of work. And it's also some sense about drawing people into action, which seemed to be more available to us through this. So it's still happening. There's no conclusions yet. Some things are spinning off from it. Yesterday, I was in a meeting. We're invited to go and talk to the Greater Manchester Museums Group. Not something I would have thought of doing as a Director of Public Health. But again, a couple of the people in that group had been to one of the workshops, had been inspired by what we were discussing there and by the level of energy in the room, and wanted to talk about what the museums could actually do. It got into a conversation about public space and that kind of sense of public realm. I'm not sure where that will go, but I'm interested in it, and I want to keep working on it. So we're not the social movement. I'm not always confident about saying that, because some people in the group do say, well, are we the social movement? I'm not sure, and they're mostly practitioners who say that, and I'm not going to deny them if that's the way they want to go. But it feels to me that what we're doing with this arts and health social movement, Live Well, Make Art, is about that sense of creating the conditions through which social movements may well emerge. I hope it's early days. It's been going for about a year. I hope it has many more years to come. But it is something which feels that we will get a lot of learning from doing it, no matter where we actually end up. And that sense of engaging with people is one that feels it has something to offer, which is in addition to what we might have going through some of the usual, the more familiar community development approaches. It feels that social movement actually offers some stretch to us there. And that's what we're looking for through the arts, health and social movement in Greater Manchester. Thank you.
Okay, so we have some roving microphones. I'm going to ask a couple of questions, but please do put your hands up now so that I can see and sense where I'm going to go. I'll come to you first, and I'll come over there and then over there. Okay, so we have heard a lot about this interplay between sort of people-driven movements or people-led movements and social models of care, and then the kind of barriers, if you like, to getting into the system. I know that you go around the world now as this global ambassador, not actually as a CEO, but as someone who tells the story of how to do these more organic models of care. Do you have any insights into how you bring this kind of organic model of care into institutions and systems? Any lessons that you've learned along the way?
Yes, we've been in a lot of countries now. I was amazed how in Asia, for example, in Japan, 6 years ago, they asked me to present it for a lot of CEOs, also for the Ministry of Health. And some of the friends now in Japan, they picked it up and they started to spread the ideas all over Japan. And what really helped was that one of these people who did it, Mrs. Satoko Hota-san, she stayed for a year in Holland, and she studied what we did very closely. So she visited the teams, she did research, and she was working for the Ministry of Health in Japan. And at the same time, the Ministry of Health decided, because of the demographics and the financial situation in Japan, that in 2025, most of the activities which are now happening in hospitals should be happening in the community. So the whole model, the philosophy fit in their policy. And what I did just from 2010 till now was talking with a lot of different people, a lot of nurses and doctors. They understood completely what this was about. So they think it's a very logic way to think about how to help patients. And they themselves started to influence the system. We took 34 experiments all over Japan, and every time we evaluated the experiments together, so they were sharing their experiences with each other. And this is the way it grew. And now in 2015, some organizations are starting to work with the model, and we developed something like a franchise model based on. And now it's all over Japan, it's well known. And I think it's a good example in that it takes so many years, so you have to be patient. And at the same time, you have to have contact with all the different levels which are dealing with these issues.
You can't just be the lone wolf, as you say, Helen. I mean, I think building on that question, I think, Alan, you had talked about nurturing, and Helen, you had talked about building leaders. There's still this tension, playing to Halima's point that this should be people-driven, about actually how do you play a role as the hierarchy or as the institution in bringing these movements or social models of care in? So how do you enable that innovation to penetrate the system?
So one of the reasons, everyone, why I think that these principles and practices are right for now is because we're in a world where the power of hierarchy is diminishing. And if you think about the kind of hierarchical structures that you typically see in health and care organisations, you know, they were designed for a different era. They were designed for a time where, you know, the jobs that people did were very stable and replicable. So it made sense to organise the work into kind of neat little silos or divisions. But like, the world isn't like that anymore, you know, in the sense, you know, things are so fast moving. I mean, when you just, I mean, you know, those of us that work in the health and care system, just how fast things are moving. In a sense, hierarchical structures and systems can't enable change to happen at the speed and the scale it needs to. So I think we're actually moving into an era now where every leader, whether a leader in an organisational hierarchy or a network leader, needs these kind of skills and perspectives, because we're moving away from a world where you have to do this because it's the performance objective, it's the quality target. we're moving to a world which is how do we support people to do the things that they really want to do, that really matter, that connect with what's in our hearts, that kind of ignite the collective brilliance of the people who use the system and the people in the system. So, just like move over because the world's going this way.
Helen, do you have any thoughts on that in terms of, I think you said something interesting to me earlier about, social movements are full of uncertainty, full of energy, they're, what you said, raging and roaring, but at the same time you have to transform health and social care in this region within 5 years. So how do you navigate that kind of uncertainty and the deadline, if you like?
I think one of the things I'm more confident about is that doing it without tapping into people's energy and grasping hold of concepts like social movements, we will fail unless we do it. That we've been trying the transformation of health and social care for as many years as all of us can remember, and have achieved, it does progress, but trying to do it within 5 years is quite a challenge. Over the next 10 years will be quite a challenge, but key to it is actually how we actually engage people in that process. And we do have familiar methods for doing that, but it feels that in my role and others in similar positions, we ought to be looking at other ways of engaging. And we will be grappling with social movements as a concept. We will get some of it wrong. But I think it's obligatory on people in my position to actually try different ways of engaging. Learn from when it goes wrong. Learn from what we need to change about the way I relate to communities in my position as part of that hierarchy, and then try to change that system. So it just feels that it's obligatory on people in this position to actually try out different ways, to try to unpick the hierarchy and actually to learn from the process of doing it. We won't get it right, but you've got to keep trying at it and then, find other ways of going around it. So it just means that we can actually get people engaged.
No, you said something earlier about creating the conditions for people to take more control of their lives. And I think it's important to note that social models of care or social movements don't apply in every region of healthcare or the healthcare system. When we were doing our Connected Communities research at the RSA, it was very clear people don't want to co-produce heart surgery, and that we leave that to a specific part of the hierarchy to deliver. However, the social movement is about those social determinants of health that you were talking about before.
Can I maybe give you a practical example of this, Rowan? Because I think it's a really important point. And I think, what we can't do is to say, social movements is the kind of the method and the approach, and we're going to apply it to everything. Because I think, in my experience, where we've used these approaches, sometimes they've worked really well, and sometimes they've worked less well. And an example where it's worked well, again, is the situation that I said about people living with dementia and antipsychotic drugs. And part of the reason it worked well there was because it was a cause. It was a situation that was so bad. Tens of thousands of people living with dementia being given inappropriate drugs, across the country that was, subduing them inappropriately. Like, nobody could argue that that was a good thing. So as the basis for using social movement approaches, it was really great. So we then, the team I worked in, we then tried to work with social movement approaches around a project that was about shared decision making and people with end-stage kidney disease. And it was a disaster. And the reason, it never ignited, it never caught. And part of the reason for that was because even though they were you look at the statistics, the data, it said bad things were happening. Patients with end-stage kidney disease weren't being given proper choices by clinicians. A lot of the clinicians didn't think there was a problem. Okay? They didn't think it was a problem that the patients weren't being given a choice. So actually, our ability to engage those clinicians to mobilise around something that they didn't think was an issue was impossible. So in that context, it's never going to work. But in a scenario, and I think again, I would be very hopeful, Alan, in a scenario where everybody, we can create a situation where we can mobilise lots of different people around a common cause, creates, I think, the best circumstances for using these kind of approaches.
Okay. So, lady there, we had a microphone there, and then I was going to go to the gentleman there. There was someone over there who's disappeared now, and then I'll come to you, and we'll see. It was the lady over there was first, yeah.
Hi, yeah, I'm Christine, fellow of the RSA. And there's one question that I think might be at the lone wolf stage, and I wonder if you can get to the movement stage, and it's something that's really down to each person, which is diet. And I sort of think that maybe our understanding of diet has been basically gone wrong. That sort of the change, the movement would be that we should embrace fat, that highly processed carbohydrates are the problem in our diet. So it's bread, it's polished rice, as well as sugar. That's really the problem with our diet. And so an example being orthodontics, being malnutrition, which has suggested it's far more endemic than we think. So I'm curious as to where you are on this. Is this something you're aware of? Is this something you think needs more research? Are you sort of aware of this?
Okay, we'll take that and I'll add another question into the mix and then do you want to, yeah.
Thank you for the talks. Just one question. Sometimes this idea of social movements in health feels a bit abstract. What would we, just got some ideas, what would we actually see people doing if there was people power? What would people be doing?
That's a good one for you, Halima.
So we could repeat
We'll take one more question. The gentleman at the back, put your hand up again. And then, yeah, no, I'm going to take them all together. Don't worry, I'm not going to ignore it. Thanks for the question. Oh, was there? Oh, oops, sorry.
Aidan Ward, I'm an independent consultant. I'm listening, my antennae are flapping as to what is allowed to be said, and there is a national divide on the panel, and I think it's very interesting. So we're allowed to be disruptive, but what I heard you say, Jos, was that in Holland things went backwards rapidly over a number of years to the point where you had to step out. That is, the decision-making system was heading in the wrong direction. I wonder what it's possible to say in the UK context and whether there's a step too far. We seem to have to be positive still, and it worries me.
Is that saying we have to take a positivist mentality and we don't like to have any challenge? Like, we wouldn't be British if we didn't have any challenge. So I think we'll bring some challenge into this. Okay, so that's a complex array of questions. The first one being, diet being a core issue in terms of people-powered health. How do people, and is this registering in terms of a core issue in the NHS as a whole? The concept of social movements is quite abstract, and do we have examples of people, what does it look like? What does it actually look like? I'm going to give that one to you, Halima. And then what is allowed to be said here? We're talking about disruptive, but is it within a container? Are we actually able to go outside of that container? And I think it would be interesting to draw upon all of your insights on that. So who would like to take on board that first question about whether, Helen, diet, is it, and getting upstream in people's well-being and health?
Probably in terms of the kind of comments I can make, are probably more around if you were going to create a social movement around diet, what would you do? So I'm kind of happy to deal with that. I don't know whether Alan wants to deal with the diet in his public, with your public health hat on, and then I'll have a go at the second.
Okay, so Alan,
bit.
start with the public health.
Yeah.
Well, I think it's one that I suppose when you were speaking, asking the question, I was thinking more in terms of diet as being broken up into various different aspects of what it is about diet and food production that would seem to me to be open to social movement. And then I was also thinking, well, am I talking about pressure groups or whatever? And I find it one that's quite hard to deal with. The government has only recently produced its childhood obesity strategy, and we were all universally disappointed. And I did wonder at that time, had there been a social movement which was actually making a greater clamour for more measures on obesity and childhood obesity particularly, maybe they would have felt better able to respond to it. And there are some of those things around, but I suppose that the one that came to mind for me, and I'm not sure this answers your question, but in Greater Manchester, in Oldham, we have a programme called Get Oldham Growing. There's a programme in Stockport called Feeding Stockport. It is part of our Health as a Social Movement programme to look at how people come together to produce community food, fruit and veg. And most boroughs will have them to some greater degree. Mainly it's about, in my mind, people come together and having social interaction through the production of food, but we are looking to take that on into looking at business opportunities and so on. Quite whether that becomes a social movement or not, I'm not sure. It does feel to me that there is something there about the production of food, rather than diet necessarily, which has more to offer, or where social movement has more to offer. So I'm not sure I dealt with your question properly, but that's what was coming to mind for me. It was more about looking at food production.
So, maybe just an example around this. So some of the work I was involved in recently was in Fulham and Hammersmith, where you have a scenario where 40% of 10 and 11-year-olds are either obese or overweight. And some of the ways that they've been working around this issue in a really kind of people-powered way, I think, are really helpful. And what it's about is understanding, you know, how do we work in ways that are about diversity and bringing different people together. So what they've been doing there is looking at a whole series of different challenges around health and fitness with young people and bringing really mixed groups of people together. So, you know, young people, families, local fast food owners, public health professionals, coders, designers, and bringing these really eclectic groups of people together to, you know, to create responses to some of these big challenges. And do you know, it's that diversity. It's when you bring those groups of people together. And I mean, the evidence on this is really clear, that diverse groups of people will consistently make better decisions than small groups of experts. So actually, our ability to kind of work in this social movement way, to embrace diversity, maybe answers that last question a little bit, actually. You know, we've got to create the space. We've got to create the space to do that. And as leaders, in a sense, what we've got to be able to do is to kind of set the boundaries, and then we've got to get out the way and let people get on with it. And we've got to trust that people will come up with the right kind of answers. And I think where leaders are willing and brave and social enough to do that, actually are, in my experience, our expectations get consistently exceeded. But we've got to create the space to do it.
Halima, on the abstract nature of social movements, what does people power look like?
It's a fantastic question. So the answer is it looks really, really different, and there are loads and loads of brilliant examples, and there's more than 20 in our report, loads that Helen and others know about. So I'll give you a few. So there are points at which a health condition is so stigmatized that the people that have had the diagnosis don't even feel able to talk about it, even in the presence of a doctor. So breast cancer, when it was first kind of sort of emerging as an issue, massive stigma. So there's been an entire breast cancer movement that's got to the point now where people wear pink ribbons in public in a way that is inconceivable a few decades earlier. So that's a brilliant example of just how far a social movement can go. Another one is around, actually AIDS is another great example, where people, again with the diagnosis themselves, just weren't prepared to accept the lack of research into that health condition. And you use this language, actually not being prepared to accept, and I think it's absolutely core to this. So again, you know, this huge switch in terms of the amount of attention put into something that really is of enormous consequence. Different kinds of examples. So I mentioned the Hospice Movement, again, just came out of powerful yet simple insights that it's simply not good enough that people die where they don't want to die and in circumstances that they don't want. And again, that insight combined with a whole set of kind of mobilisation and change over periods of time gets us to a place where we are now talking about a good death. Again, just things that were just not talked about, not considered. So many different. I mentioned the disability movement, again, a brilliant example of work over many years. So I hope that helps to bring it to life, which isn't to say that some of the smaller examples of change that we're talking about aren't also relevant. And I think again and again we hear this idea of the social model of health, and actually to what extent is all of the work going on around the social model of health actually building up cumulatively to some potentially very big transformational changes in terms of a shift, if you like, from a biomedical model of health to a social model. And so that's sort of, I hope, brought it to life a little bit more. But just a quick couple of thoughts on the third question around what are we allowed to say, which is brilliant. So I think I would take us back to that raging and roaring bit. This is not about being polite, I don't think. It is not about asking permission before you decide whether or not something you want to say is acceptable. But it is, and this came out brilliantly because there was sort of a pre-session to this public session tonight, and Mark Swift, who's in the audience, said something that I think was brilliant as well. It's also judgment about how much to rock the boat and when to rock the boat. So there is a judgment there as to, in order to achieve your aims, when is it the right time to be somewhat polite and somewhat playing the existing game, and when is it required that actually you just shake things up and take things by the collar, if you like. And I think that's something that came out very, very powerfully earlier on.
So Jos, I'll take that question to you then. I think talking about rocking the boat, I think you do that for a living. And I'm interested in how comfortable you felt with using terms. I think you said abnormal regulation and useless indicators when you were talking. How comfortable do you feel with that kind of provocative language? And then we'll end, I think, with Helen, if you could do a thing, because we're slightly running over time and I know that it's difficult for people to stay. So how easy has it been to disrupt the system?
I think when you have a clear message which is understandable for a lot of people, then I think it's very strong that you use just the words as they are. So if people feel it this way, so if I talk with nurses in London and I see how their daily practice is, and we have had a lot of delegations from England, and they see that they know from the past that it can be done very differently, but find it very difficult to find ways to rock the boat. But I think it's time, and it's also already happening. So there are several organizations are pioneering. We are working together with Public World in Scotland and England. There are in total, I think, more than 10 organizations who are pioneering. So it's just a matter of time. But I think what I see is, and that's different than in some other countries, that the British people are very proud of the principles of the NHS. But what I see is that the daily practice drives away from the principles. So, but in Holland, there is at the moment a discussion that we should accept the principles of the NHS. Not the practice, but the principles. So the more the practice is driving away from the principles, the more need, I think, is for rocking the boat. And I think this time is right. And I've talked with a lot of people in all levels of the NHS, and they all recognize it. So that's not the problem anymore. But then this British politeness, I think, is sometimes a problem.
And it's public debates like this are part of making it happen and making it a reality. Helen, if you'd like to finish.
Yeah, so I just thought I might finish with a story, if that's okay. And this story is about Sarah Duggan, who is Chief Exec in Worcestershire, who leads the local transformation and planning. And so I went down and did some training with some people in her organisation, and afterwards a whole group of them came to her and said, we want to be rebels, we want to be the people that rock the boat and stay in it, so we want to have a rebel group. So the organisation, the people that lead change and improvement in the organisation have been supporting this group to be the rebel group. And the rebel group have been given some of the biggest challenges in the organisation, the system, to sort out. And they sort them out as a rebel group. So they're in the hierarchical system, but they're on the edge, being the rebels, and they're being given permission by that leader to work in radically different, refreshing ways. And the relationship that's been built between that leadership team and that rebel group, very, very trusting, very, very capable. And what's great now is that they found another rebel group in Vancouver coastal healthcare system in Canada. So now the Worcester rebel group and the Canadian rebel group are like rebel partners, and it's kind of spreading. And it, what to me, it's a really great example that it isn't like this is the hierarchical system and this is the movement or the network or the community. Actually, I think that the best leaders in our system are actually understanding the power of both, and we need to work with both.
So I'm feeling we should have some kind of rousing chorus of rebel yell by Billy Idol. But sadly, we've run out of time, and we have run slightly over time, so thank you for bearing with us. So we need to wrap up the session. You can find more information on social movements in health in this report and on our website. As I say, we're one of 3 partners in this, and we're looking forward to working with NHS England as this work progresses. Sorry if I didn't get a chance to take your question. I know there are always more questions than we have time for, but we do have some refreshments downstairs in the Benjamin Franklin room now, so please join us, and there are RSA staff to show you down there. But finally, please join me in thanking this evening's terrific speakers, Halima Khan, Helen Bevan, Jos de Blok and Alan Higgins.